we will move to the next speaker, who is Dr. Stefan Fernandez. Dr. Stefan is the Chief of the Department of Virology, Armed Forces Research Institute of Medical Sciences. He will present on dengue virus transmission in a cohort in Thailand. Can you believe me that the cohort was maintained for several decades? And there's a lot of good work from that cohort. So Stefan, please.
Thank you, Dr. Usa. Definitely, this is a cohort to speak about. Hopefully, you guys can see my slides. For clarity, for clarity, this KFCS cohort itself is the very last study on a very long study that has definitely taken decades. This I want to call it the last leg, Dr. Usa. But yes, so my name is Stefan Fernandez. It is a pleasure to be here, and thanks, Dr. Usa, for organizing this group and for your invitation. I want to speak to you about our Camp and Pet family cohort study, one that has been placed since 2016, but it's the last iteration of a long list of studies that we have kept in Thailand. A quick disclaimer, these are just my opinion, not the opinions of the United States Army or the US government, right? We have a particular objective and a very simple one, but one that we think is very, very important, that what the KFCS, we believe, is going to help us solve. And this is to understand how the transmission of the dengue virus and the burden, whether they actually are focused on family units living in a single household, and that the spread of the dengue virus may be determined, but actually by the sum of the family members' previous dengue virus experience. These are new questions that we have built on the back of prior studies. The study started in 2016. There's a lot of data that has not been analyzed. I will share with you the model of the study, how it is being executed, and perhaps a few of the conclusions that we have arrived to. But at the end, we're just trying to determine the incidence of dengue in a prospective cohort studies made out of family units in Camp and Pet, containing family members that are on more than one generation, probably under a single roof. We have several aims, which is to correlate pre- and post-infection immunological profiles within the family members with disease outcomes across sequential dengue viruses, in children and adults. We want to define potential disease-modifying roles of maternally derived dengue antibodies in infants. And we're trying to define the clinical immunological outcomes of sequential dengue infections in multiply exposed older adults, which are part of our study. And finally, we're trying to identify risk factors for dengue transmission in these household units. Although I'm sitting here with you, and it's a great pleasure, the two people that actually are making this happen, the first one is Dr. Katie Anderson. She's in the United States. She's in Sunny State University in New York. And she's been working with this cohort and this group for many, many years. The model of the KFCS study was recently published in the American Journal of Epidemiology. You can go there and see exactly how this cohort is being built. The second person that actually deserves credit, most of the credit, is Dr. Daruni Budari, who is the section chief of our clinical station in Camp and Pet, CAVRU, who is the actual person that actually makes this study move forward. And that she just published a paper in ISNTD, speaking of the correlation between dengue illness history and seropositivity in rural places in Thailand. This paper is in ISNTD, and the data is coming out of this KFCS study. The study model is literally very simple. Starting with a pregnant woman, which is enrolled, we want to maintain a family household. That not necessarily means in the same house, but definitely a household that keeps at least 2 generations, the young parents, the newborn, and probably the parents of the parents in the same cohort. And we try to enroll as many of these families we can in Camp and Pet, and we follow them for a number of years. And this is data that we're looking. We start with a cord blood collection. Then all subjects, the mom, the baby, the parents, siblings, and so on, they are followed for annual collections, but there is also an active surveillance component to it, where people are being interviewed, and if they display a number of signs and symptoms of disease, then we collect blood samples to be tested for dengue. If these blood samples are positive for dengue, then we collect samples from the contact information, and we do a variety of testing. If the samples are positive, if the samples are negative, we just collect data from the index cases, and it just goes up into the biological pool. The study site is in the province of Camp and Pet. If you are not familiar with Thailand, it's just a few hours north of Bangkok, and we work in 2 sub-districts in the province, 2 districts in the province. The province Muang Camp and Pet, which is a little bit here on the north, and then Kanu, what we call Kanu. And in them, of course, there is a number of hospitals, there is a number of sub-districts, and there is a number of public health centers where we actually do the community engagement, we do the enrollment, and we do some of the active surveillance and so on. So it's a very large cohort that has people that actually live in rural areas and areas that are far less than rural. For example, people that live in the main city of the province in Camp and Pet. We started this study around 2015 and 16, and we were able to enroll during that first initial period 268 families that made up a little bit under 2,500 family members. Every year, we try to maintain a level of enrollment that keeps the number of participants around 3,000 or a little under 3,000, but keep a number of families about a little under 500. You know, from year to year, we lose a number of people. Some of them we just don't collect the cord blood of mom, and that's enough reason to move on. Some people, after 5 years of the study, they just move on. A number of people just move out of the Camp and Pet study site, and we can't. We are right in this period. We have only enrolled 2 people, and we have lost a lot of them, which is not a lot, but the normal number that we would expect from prior years. But we have failed to actually make up for the time period, and we were starting to start enrollment again in June, but because of COVID, community quarantine measures and so on, we actually have been unable to catch up on our study. So this is the first year since 2015 and 16 where we actually have actually lost a considerable number of people and family. But we hope that we actually going to be catching up very, very soon. By age, by looking at during the time of enrollment, obviously the vast majority of our subjects are the newborns that are here on the left column, and their mom who are here, most of which are between the ages of 16 years of age and 40. But you see that we have a number of subjects that go all the way up to the very old age, 70, 80, and even young. It's actually makes for a very interesting mixture of people. You understand that we don't go out explicitly looking for people that are that advanced in the age. They themselves are 100% likely to be already seropositive multiple times for dengue, but they do add to the immunological weight in the household that contributes to infectivity and the kinetics of the viral distribution in the family. When you were looking at the seropositivity by age, obviously the vast majority, this slide is slightly misleading. It says newborn, but understand that these newborns are under the age of 6 months, and what we're testing here is their core blood of the mom, which is probably 95% already seroconverted. But you see that as the kids move into older ages, there is a percentage of them that are seronegative. They do become seroconverted as they get older, obviously. By the time that they are 30 or a little older, they are virtually, the entire group is seropositive for dengue. At least one event. And this is something that we do by measuring, by looking at neutralizing titers PRNP. So this is our weekly follow-up data log, and we have kept it there so you can take a look for the last 11 months, starting in May of 2020, which is when the COVID, I would say, COVID outbreak starting to get a little more significant here and in the world, the highest number of cases. Number of May through May of 2020, this is the number of households that we have on our third column, and the number of houses that we have. Understand that some household may have 2 houses within the same vicinity that just happen to be of the same family. And this is the number of follow-up that we have. These are just weekly called the people that are followed weekly and interview. Very few people are missed. A very small percentage of people we cannot grab. These are people that drop out of the study or for whatever reason we cannot follow up. This is the number of people with fever that we have reported over the last 11 months. And these are the people with cough. These are the people with sore throat. They are not uniquely separated, these columns. Some subjects may have 1 or 3 of the symptoms, but you can tell that the number of acute events, that's just what we call, tends to happen around June, July, August, September, and October, which coincides with dengue season mostly. When we look at the number of acute events that we have collected since the start of the study, or we started doing the active surveillance phase, which is in October of 2015 through May of 2021, we have had 410 acute events. Most of them, again, it's happening between the month of May and August. I would say it's most years we have the same pattern, but not necessarily so. 60% of all these cases are from adults, and the rest of the people are just younger than the rest. Let's say this is the number of reported fever cases, yes, from day 1 and 2. When we compare this curve, I want to say, with what the Ministry of Public Health reports during dengue season, you see that they coincide very, very well. This is the last 3 years, I believe, from the Ministry of Public Health right here in Bangkok, and this is the dengue situation in Thailand this year through week 17, the year before, and the year before that one here. So we have looked at all these household contact investigations as well, of which we have had 43 dengue household contact illnesses that were positive by PCR, and that is generated 39 household contacts that were investigated. And you have by color here from 2016 to 2021. And you see that the peak and the are usually around the rainy seasons, which obviously coincide with dengue. The exception being here on the right, which are 2018 years somehow. When we look at those household and in this case investigation, that happens to be positive for dengue. You can see here that first 2 years, 16 and 17, in our cohort were dominated by dengue 4, which is somewhat unique in the Southeast Asia region, with some exceptions in the Philippines, dengue 4, which also happened to be the most prominent serotype in Thailand in general. And then on the years 2018, 19, and 20, actually the most dominant serotype was dengue 1, that was not necessarily all in agreeable with dengue 1 was the most prominent serotype in Thailand. But in the year 2019, KFCS, we actually have more dengue 2 than we have of dengue 1. And we actually, in 2021, as of now, dengue 2 seems to be the most prominent serotype in our KFCS cohort. So this is our dengue household contact summary. We have had 222 family members that have been followed up between day 0 and day 28. That means that they were triggered, and they were triggered right in this case, and were consented to be part of the follow-up. 9 of those subjects were positive by PCR on day 0, and 9 of those subjects developed symptoms during the first 28 periods of the follow-up. Usually the symptoms were between day 5 and 28. A second acute blood collection was done and measured by PCR as well. 3 of them actually turned out to be positive. 21 of these contacts were positive by ELISA. This in not just the people that were positive by PCR, but others that were PCR negative, but you could still determine seroconversion by ELISA. 6 of them were primary dengue infections, most of them, of course, very, very young cohort, ages 2 months to 3 years old. And 15 of them were secondary by dengue infection, which are 3 to 88 years old. Yes, we did have people that reported with fever and were followed up even at that very old age. The age breakdown of the dengue positive contacts that we have, obviously either by PCR, and by PCR assumes that there is also an ELISA positive, but also by ELISA or HAI only positivity, that is assuming that there is negative or no PCR was taken. Not surprisingly, a lot of the very young cohort, most of them were seroconverted by HAI, meaning that these kids, most of them were experiencing a contact or an infection with dengue that was not developing necessarily symptoms, but the proportion of HAI positive that were PCR negative does vary over time. Interestingly, in some of the very oldest cohorts, we have no proof of PCR positivity, but there is definitely signs that these people are increasing the titers or seroconverted, assuming that they were seronegative between annual follow-ups. There is an entomological element to this study, one that I have very little to talk about, but one thing that we're doing is that we're looking also at Aedes aegypti vectors and we measure whether they are by PCR, whether they're positive for dengue or negative for dengue. And we collect these mosquitoes routinely when we have index cases or some of the follow-up cases that are positive for dengue. And then we're trying to make a correlation between the mosquito load in the house, because they are collected within, I believe, 20 meters from the house of the PCR positive cases. And then we measure it by PCR. And some of that data is going to start leaking out very, very soon. So our current status is that we are in the 5th year of the illness surveillance, and we are starting to enroll that 6th year right now in June, although we already know that it's not going to be happening. We have a lot of lab testing and data analysis that is taking place. Some of the stuff is going into the paper, and soon it's going to be able to share, but I do want to share a couple of things that we already determined, 3 of them as a particular. One of them is that the rate of decay of maternal antibodies in the newborns is always the same, in that by 20 or 24 weeks of age, there is actually baseline antibodies circulating in the kids, regardless of how high the maternal titer was, which is actually very interesting. In other words, hyper titers in the serum of the mom don't necessarily translate into longer protection in the newborn. that's one thing that we want to do. And another thing that we're doing is trying to make correlations between the likelihood of symptomatic infection or any infection of any type and in association with land use in the vicinity. And what we do is that using this program, RGs, right, we can measure the degree of development in the vicinity, the degree of vegetation of the vicinity, and the degree of water bodies in the vicinity or immediately in at the site of the household. And then we're trying to make correlations between those, right? And the significant and the risk of dengue seropositive, right? And also whether these can be predictors or not of seropositivities. And you can see there that we have some significant correlations and some less significant correlation between land use, right, and seropositivity in our study. And this is just using data from the first 2 years or 3 years, and there is data that is still being collected and is going to be presented. Another thing that we have discovered, it goes back to the very first comment that I made, is that the KFCS, right, is the newest iteration on a long string of prospective studies that seek to enroll residents in the province of Kamphaeng for very young age and follow them through a number of years. This actually started before 1998, but alas, we have had at least 20 years where we are examining either by HAI or by PRNT or some other method the rate of seropositivity amongst the cohort at the time of enrollment. And what has become apparent by looking at this data is that the force of infection, at least in that cohort, has changed over a year, where people are, as an average, older in age by the time they experience the first dengue infection. Whether this is common in other places or not, it's probably very, very likely. Towns, countries, and vicinities have changed drastically over the last 20 years, and that, of course, has shaped the epidemiology of dengue, at least in Kamphaeng. But over the years, it's just becoming apparent that people are older by the time they come across the dengue virus for the first time. And of course, there is a lot of data that we still haven't completed and analyzed here. You can see that we're missing a couple of years from the KFCS, but you see that the data that we have goes back to 1998. There were cohorts that were completed before, but I'm not really sure why that was not included in this graph. And there is a lot of questions that we ourselves are asking, and we hope that in the next few years we're going to be able to respond. But this is all I have to share with the group now, and I can take questions at the end of the session or at any other time. Thanks, everyone, and thanks, Dr. Musa.